It's hard to believe how long the journey has been on adding the pharmacist to the care team, but we are thrilled to be part of helping to spread this knowledge. This is our 303rd University of Best Practices or Right Care gathering of some sort since 2008, when we held our first statewide summit with the Department of Managed Healthcare and the University of California, multiple campuses. Lots of experts from around the state have been involved ever since, including all the major universities, the UC's schools of pharmacy, public health, medicine, public policy. We've got the University of Southern California, Stanford, Blue Shield of California. And here we have Scott Flynn just in time. Thank you for joining us, Dr. Flynn. And thank you for your support of this program. We have a consistent posting of our slides and videos, and we are going to try to make enduring continuing medical education out of this program, which is going to relay critical information about the importance of adding a pharmacist to the care team. If you would all please use the Q&A feature instead of chat for questions for our speakers, and any operations questions, we would appreciate if you would email them to albert1030@berkeley.edu instead of chatting that out to the whole group. We are ever so appreciative of all of our supporters, including the Stroke Awareness Foundation, the Tennis Getter Foundation, the Health Trust, our university partners, State of California, Los Angeles Public Health, and our biopharmaceutical partners, supporters, I should say, not partners, Johnson & Johnson, Genentech, Novo Nordisk, Amarin, and Boehringer Ingelheim. Next slide, please. We are very appreciative also of the partnership that we have with the California chapter of the American College of Cardiology, thanks to our chairman, Dr. Bill Baumer. And I like to start each of our programs emphasizing the importance of the topics that we work on. We know that there are major public health campaigns on the conditions that we work on, as well as the main cancers that have standard screening programs: breast cancer, cervical cancer, colorectal cancer, prostate cancer. But I want everyone to do their best to memorize that when you look at the deaths starting in the 35 to 44 year range from hypertension, from heart attacks, strokes, they are a higher number already by age 35 to 44 decade than those cancers that we have standard screenings for. So we really need to change the cultural perception about how early these conditions strike. We have a cultural misconception that heart attacks, strokes, and hypertension deaths happen starting when people are in the Medicare age, and that is just not true. This data is from the Centers for Disease Control Wonder database, and it's very motivational to realize just how impactful this work is that our leaders have been coming together, collaborating on for now 15 years. Next slide, please. So we've been talking about adding the pharmacist to the care team since 2009. I believe Steve Chen hosted us at RAND. We were at RAND together, bringing the medical groups together and health plans and state officials, et cetera, for now more than a decade. And we've got fantastic data now which others will be sharing. Next slide, please. So our chairman, Bill Baumer, who is also the chairman now for the California Department of Public Health master plan for cardiovascular disease, and very famous professor of cardiology at UC Davis. I won't go into details about his bio, but Dr. Baumer is leading so many efforts in the state, and we just very much appreciate his work with the Right Care Initiative. Next slide, please. Dr. Baumer will talk us through our agenda now and tell us a little bit about the work that's going on at his fine institution, UC Davis. Thank you, Bill, for leading us through this next section.
All right, well, thank you very much and welcome everyone to today's, I believe is going to be a very exciting program. I wanted to go back in time just a little bit. So I wanted to go back to my last March 15th in clinic, which, as you know, is the Ides of March. So I'm running 15 minutes late. I have 15 patients to see in the afternoon for that. The first patient walks in and they have a problem list of 15 problems. They are also on 15 medications that is listed on their chart. As they walk in, they hand me another list of their medicines, which they think they're taking, which does not agree with what's on the chart, their 15 medicines. So they're all different at that point in time. I have 15 minutes to see this patient, and I can't bring them back right away because my slots are booked out for the next 15 weeks. So it's going to be at least 15 weeks before the chance of them ever coming back or being part of it. So I've got all these problems. I'm 15 minutes late. They walk in, and that's not what they want to talk about. They have multiple other problems to address in that 15-minute slot to look at that point in time. So what am I to do at this point in time for that? As Shakespeare said, beware the Ides of March. But in this particular day, you're going to see that we're going to have two pharmacists present significant options to get you out where you might even save your career and save lives at the same time. So the presentation today will discuss that. And in fact, we look forward to it because my next March 15th at UC Davis is going to be different. Why? On July 1st, we're hiring a pharmacist for my high-risk clinic. On July 1st, they will take over. And what am I going to do? I'm going to assign to that pharmacist the ability to sort out those 15 different medicines on the chart and different doses that are there, to address things like blood pressure, where it needs to be titrated up, and it can't wait 15 weeks before the next visit for that. The pharmacist is a very valuable person in the team, and UC Davis and our clinic have decided, based on prior presentations by Steve and others, that we have now seen the truth and the evidence, and we are pursuing hiring as of July 1st at UC Davis, a pharmacist for our high-risk clinic. I hope you stay with us today to learn about this and to hear about it again, because I think you're going to hear a very excellent presentation by two pharmacists who have played a big part in bringing pharmacists into the team to not only improve healthcare, but to save careers and lives as we go on. So we're happy to present today. And I think Scott Flynn is going to do the presentation of the presenters today. Thank you.
Thanks a lot, Bill. Hi, everybody. Scott Flynn, Medical Director, Blue Shield of California. just a quick anecdote to get us off. Much like what Bill was saying with his 15-minute, 15 problem and 30 med patient, we had a bit of an epiphany at my old group when we were working with pharmacists initially. There was a lot of reticence. This is about 15 years ago, a lot of reticence about having pharmacists work on a bunch of different healthcare issues. It was thought to be encroaching on physicians' turf, and basically what would they know about treating hypertension or other things like that. And the interesting thing was we had a Coumadin clinic at the time, and it's now called an anticoagulation clinic, but we had a Coumadin clinic at the time. We had a nurse who was running it, who was doing a pretty good job of it, and doing pretty well with the metrics, and things seemed to be going okay. And then things got busier at other parts of the clinic, and we had to move the nurse, and we actually hired a pharmacist to take over for the Coumadin clinic. And within probably 4 or 5 months, the Coumadin clinic got even better, and it was starting to reach national 75th percentile, national 90th percentile for some of the metrics, and quite proud of what we were doing with that. And then we were getting involved in right care at the time. And one of the tenets of right care, as we know, is having everyone work to the top of their license and teamwork and all that. And what do you have the pharmacist do? Well, the pharmacist can help you titrate meds and get folks to goal for hypertension with a collaborative practice agreement and an algorithm, and work both themselves and with pharmacy techs to get folks titrated into goal quickly. And when we were approaching this with a group, we had, again, a lot of resistance. It was thought to be, geez, what are they going to be doing next? Treating diabetes? Well, okay. And the two ways we got folks to understand what this meant and how this could really help them, again, using Bill's example, you're a very busy provider. You've got 15 problems and 30 meds. What are you going to do? In this particular case, when I met with the providers, I asked them, so let me get this straight. You're letting the pharmacist deal with anticoagulants, which of all the meds we deal with, absolutely have a propensity to cause fatal injury. We know that. And underdosing also can cause fatal injury and or lifelong debilitation with strokes. And you're okay with them treating that because that's a mess to deal with, right? And that's why you really don't want to deal with it. They eat a salad and you have to adjust all their Coumadin doses. You don't want to have to deal with that. And so you're happy to give that to them, but not hypertension? Really? That's what we're going to be like? So that kind of brought them around a little bit, said, yeah, I guess so. And the other thing that brought them around was we had a clinical champion. One of the internal medicine docs said, you know what, I'll be the first one. I'll be your clinical champion. I'll be a pilot. And he went in, and his blood pressure control rate was around 55 percentile at the time. And over the course of 4 to 5 months, he got up into the 75th percent of control from 50. And then he got up to 78% control by the time we had our next quarterly meeting. And we presented the results, and everyone was kind of amazed. And given again that we're letting pharmacists treat anticoagulation, but not hypertension, really? And seeing the results that Dennis got, everyone was kind of like, then I had the opposite problem, and that was I didn't have enough pharmacy time. So I had to go out and figure out how to get more pharmacists involved in all this and all that, which is a great problem to have. And the numbers for our group became national 90th percentile, and we did very well with that. So huge proponent. I personally was not a fan when I started, and then I came around when I saw the effects they could have and just how good they can do, attention to detail, all the things that we really love working with our pharmacists for. So with that as my background, I am going to introduce both Tony Morreale, who is the head of the consultant for clinical VA policy and development. Tony, how long have I known you now? Over 10 years, maybe 15. Again, I don't want to date you, but it's been a while. Yeah. So Tony's done, you can read his bio there, exquisite work that he's done, and made a huge impact literally across millions of lives. So it would be fascinating to hear from Tony today. And the other partner in crime that I've worked with in the past is going to be talking later on also is Steven Chen. And Steve's done great work there at USC and is really a dynamo in how we're attacking many disease states, including hypertension, across the spectrum here in Southern California. So without further ado, I'll turn it over to Tony.
Great, thank you, Scott. And I'm really happy to be speaking with Steve again. We've had an opportunity to speak together a few times over the years as well. And I look at my role as driving clinical pharmacy practice inside the federal government, inside the VA, and he's been the champion for that outside. So I think it's been great to work together, even though we work separately on these. So today I'd like to share with you some of the experiences that we've had in the VA moving clinical pharmacy practice kind of into really the 21st century and trying to do a lot of the things Scott had just described, which is really integrate them as true team members. So next slide. So first, for disclosures, I don't have any conflicts of interest. And really, for the objectives of this discussion, I would like to describe the genesis and success of the broad integration of clinical pharmacy practitioners, which is what we call advanced practice pharmacists in the VA. We have a terminology called clinical pharmacy practitioner, and we've integrated them heavily into primary and specialty care focused on comprehensive medication management. And I think, as Dr. Flynn mentioned earlier, you know, we don't want to do the diagnosing, and we're not out there to do surgeries, but we're sure good at doing comprehensive medication management. And we're going to show you some of that information. I also want to talk about the outcomes, especially as it applies to the quadruple aim of access, quality, cost, and then now moving into both patient and provider satisfaction. Next. So first of all, you know, one of the driving forces in the VA has been an ongoing shortage of providers. And this is not unique to the VA, but it's across the healthcare system. And it's estimated by 2023, which is not far away, that we will have between 54 and 139,000 shortage of providers in the healthcare system. And so we really need to work as teams to fill those gaps. On top of that, we have this aging population who have not only in volume, but in complexity, the number of diseases they have. And with the complex, increasing complexity of diagnostics, it requires more provider time to do some of the diagnostics, and also those diagnostics aren't only the initial diagnostic, but following the progress of the patient over time with a lot of the new complex diagnostics. And then there's an explosion of medications, very difficult to keep track of. And in fact, you know, you'll see that we've branched out a lot into pharmacists being specialists in areas, because there's just too many medications for even our primary care pharmacists to know how to manage effectively. Now, we do know that pharmacists have a lot of advanced training, and that has advanced more and more over the years. And we are recognizing that lower paid employees, in this case, a pharmacist, can really do the tasks as well as some of the higher paid employees. So having everybody work at the top of their license lowers the overall healthcare cost. Next slide. So the rationale for interprofessional practice, I've already kind of alluded to, but really what we want to try and do is improve access, number one, and to be able to handle that volume of patients that we have coming, to improve the health outcomes of those with chronic diseases, to do it in a manner that is improvement in safety, and really tries to, from an inpatient perspective, lower lengths of stay, decrease clinical errors, and then again, going towards the quadruple aim, decrease staff turnover, staff burnout, and then of course for our patients, most importantly, decrease morbidity and mortality. Next slide. So this is kind of the model that we developed within the VA. You are looking at the primary care model, where on the left, where you have a primary care team, which is made up of a number of clinicians. And then you have specialist teams like cardiology, neurology, GI, all of those types of things. And we really see the clinical pharmacy practitioner or provider being the bridge between those two areas. We can have pharmacists who work independently in both of the areas, but they often are the people who might look at a patient and try and manage something like diabetes and say, well, a particularly complex patient maybe needs to go to the diabetes pharmacist who works within the specialty care group. So we see that we can bridge both of these areas and manage different cohorts of patients between them. Next slide. So this was the primary care model that was originally built by the VA. And you can see that they had what they call the teamlet, which was essentially for every provider, they would assign a RN care manager, a clinical associate, and a clerk to help run the clinic. And so those were like, you know, one FTE per group of 1,200 patients. And then you see up in the left-hand corner the other team members, which included the clinical pharmacy provider, and they were assigned at a different ratio. So for every 3,600 patients, you had a full-time pharmacist. And on top of that, that didn't include anticoagulation, which was a carve-out of this model. And then likewise, we had social workers, nutrition, case managers, and then of course our trainees, residents, students integrated into the system, as well as integrated behavioral health. Next slide. So just to give you a sense of where we are right now, in the VA, we have almost 10,000 pharmacists that work for the VA. A little over 51% now are clinical pharmacy practitioners. That means they have a scope of practice with prescriptive privileges, and their primary role in the healthcare system is to improve access, improve prescribing, and do comprehensive medication management. So we have truly made it to the point where we are a clinical profession, even though the other 49% are still involved in distribution, administration, education, and the like. But you could see from here that of our pharmacists who have a scope of practice, 86% of those people have residency and or board certification. And the breakdown is down below. So these are very highly trained clinicians where there's no doubt that they can manage patients' comprehensive medication management. So it gives a lot of trust to the primary care and specialty care providers that we have pharmacists that are so well trained. Next slide. So when I moved over in the VA to central office and we started the clinical pharmacy practice office in 2010, we had a little less than 2,000 pharmacists who were advanced practice pharmacists. And as you can see, in around 2011 is when our primary care medical home or PAC team started off. And we've grown significantly over time in the number of clinical pharmacy practitioners. And so as shown here, we've gone from a little over nearly 2,100 to almost 5,100 pharmacists that are doing this. So a big testament to the VA's belief that these clinical pharmacy practitioners can really help improve care in our patients. Next slide. So I wanted to just briefly describe, we have a project or a program that we developed internally back in around 2012 called the PharmD Project. And that is that pharmacists achieve results with medication documentation tool. So basically, every time a pharmacist is referred a patient and has a visit with that patient, prescribes for that patient, they document through an intervention software package that we developed so that we could track of all the referrals and all the people that are seen what kind of patients are being seen by the pharmacist. So you can see here that diabetes is our #1 referral from providers. Not a surprise, considering we have over 25% of our VA population has diabetes. And if you look down the list, we have anticoagulation, which we've had a giant anticoagulation program for a long period of time. But #3 is mental health. And so this may be surprising to some of you, but others of you who know the VA know that we have a higher proportion of mental health patients. And so we've really, in addition to diabetes, hypertension, hyperlipidemia, as you can see here, we have a whole host of things that pharmacists are managing in their disease states. And there's a lot of overlap between these. So if you think about it, for example, with mental health, a lot of the mental health drugs have a propensity to cause diabetes. And so you don't have patients that just have one problem. So this is their primary referral. So for example, a patient might be referred for mental health, but also have diabetes that's out of control, may have hypertension or hyperlipidemia. So, you know, the pharmacist is still managing all of these problems, even though their primary visits might have been the items that are on this list. And then the other thing I'll just mention is you can see things like tobacco use disorder are very much consequential in terms of treatment of hypertension, diabetes, hyperlipidemia, and the risk for cardiovascular disease. So we cannot treat these diseases in a vacuum. And so we've spent a lot of time in our development of clinical pharmacy practitioners to make sure that they're not working in a silo and they're not just treating one disease, but they're treating the entire patient. You can see here in FY21, pharmacists saw somewhere around 9 million interventions with patients. So our volumes are quite high in the system. Next slide. Interestingly, we've also measured modalities. So you can see here that we do a fair amount of telephone care. So we have built a virtual system from the ground up right from the beginning. And it's kind of ironic that during COVID, things started switching over to more telephone-based, more what we call VVC, which is Video Connect system, or clinical video telehealth. But pharmacists have been doing it this way since the beginning. Some of that was because there was no space. Some of that was because a lot of what they do can be done quite successfully through telehealth. So you can see about 50% of all encounters by pharmacists are via telehealth. Next slide. So when we look at the pharmacists and kind of their roles, we have primary care pharmacists, but then we also have pharmacists that work in these specialized areas. Now, some of those specialized areas in VA have tremendous overlap. So for example, as I mentioned before, mental health has a lot of patients in mental health that are seen in primary care. They're not seen in psychiatric clinics, psychiatry clinics. They are seen in primary care for their disease. And likewise, a huge proportion of our primary care patients have pain disorders. And I'm sure that all the physicians that are on this call can verify that that is a real common issue. And the interesting thing about the intersection of all three of these is mental health and pain are often two areas that the primary care physicians don't feel as comfortable managing. And so similar to what Dr. Flynn had mentioned with anticoagulation, they're more than happy to let the pharmacists help them with reducing opioid doses or managing patients' mental health disease. In order to do that, we have scaled up training of all of our pharmacists in primary care to treat all of these different diseases. So where your pharmacists, when we first started in primary care in the PACT, were primarily focused on diabetes and hypertension and hyperlipidemia to some degree, now they are broader in their scope, and they are treating mental health disorders, they're treating pain, they're treating other areas, COPD, congestive heart failure, so that we don't have to transfer the patient from the primary care setting into the specialist setting. So this has kind of been one of our goals, is to really improve the efficiency of our primary care pharmacists by letting them be able to manage these other diseases that perhaps before they might not have felt comfortable with, but with additional training, we've got them there. Next slide. So when we talk about access, this was our primary push in the last 3 or 4 years, is what does the pharmacist provider do for access? And so we worked on study designs to look at our real world implementations within our primary care teams. When we added a pharmacist, what happened to the primary care team? And what we were able to show is that by adding the pharmacist, you can significantly improve access. The provider backlog times for a clinic visit were able to drop because they were able to offload many of their comprehensive medication management patients to the pharmacist. And in fact, what we were able to demonstrate in this publication in AJHP was that 27% of all primary care return visits could be averted by adding a pharmacist to the team. And so, you know, obviously the pharmacist can not only take on those patients, but is doing it at a lower cost, but they're also doing it in a way that sometimes, as was described earlier, has either equal outcomes or better outcomes for the patients. So this was a real big publication for us in terms of trying to prove that pharmacists could improve access to the team. Next slide, please. So this is a really busy slide, so I won't cover that slide in all its detail as far as the each of the statistics, but basically what it shows is that compared to physician interventions, clinical pharmacy interventions, and the treatment with TZDs, in this case in diabetic cohorts, led to greater reductions in hemoglobin A1C in patients that were in rural settings that were seen by the pharmacists than those that were seen by the primary care physicians. So basically, again, what we were trying to look for is, as pharmacists take on these patients, most importantly, right, is do no harm. We want to make sure that we have at least equal outcomes to what our physician colleagues were attaining with some more efficiency and a lower overall cost. So, and the references are on all these slides if you want to look at them in more detail. Next slide. So when we look at this study here, looked at the quadruple aim, again, the lower cost for the same outcomes. So in this particular case, we did a propensity matching for baseline characteristics of over 12,000 patients in each group from 53 different medical centers in the VA, and we compared pharmacist managed diabetes to usual care, which was in this case primary care providers. And you can see based on this that over time the mean hemoglobin A1C reductions in both groups were equal. So very happy that our physician colleagues were happy to see this kind of stuff, because that's really gives them a lot more confidence in handing off their patients for their med management. Next slide. This is some data I just wanted to show you. It was quite interesting. It has not been published yet. It has been presented in a poster, and our publication is pending right now. But we did an analysis because there were some people who had criticized our system, saying that you know, it's probably that the pharmacists are getting equal outcomes or better outcomes because they're getting the easy patients. In other words, they're cherry picking the easy patients, and the primary care providers or the other specialists are keeping the more difficult patients. So we actually designed a study where we created tools and looked at tools that were out there and created our own tools that predicted complexity of a diabetes patient. This might be the duration of time they have diabetes, the number of diabetes drugs that they're on, the number of comorbidities that they have for diabetes, they're on insulin, all of these areas, and you'll see this over time when the publication comes out. And what we did is looked at all of the patients that are being referred to the physicians, referring to the pharmacists, or the physicians keeping them in their panel. And what this graphic shows you was that there are significantly more complex patients being seen by the pharmacist. And I think after talking to a lot of my primary care colleagues and friends, some of them said this is not surprising. If I was the physician, I would give the pharmacist my most complex patients because they take the most time. And I need that time to be able to treat the other people. But now we have the evidence, at least in the VA cohorts that were seen. And this was, I don't have offhand our numbers here, I guess, but it's a huge number of patients that we analyze. So we're really interesting data that's going to be coming out on complexity. Next slide, please. One of the other things we published back in 2018 was an analysis looking at the patients who were referred to the pharmacist versus the patients that stayed in usual care. And based on the diabetes cohort, so if they were at a baseline hemoglobin A1C of 9 to 10 versus a baseline of greater than 10, and you could see there was over 2,000 patients in each of those cohorts. And then, of course, we also looked at their hypertension and hyperlipidemia. And so you could see in the two diabetes cohorts, we had about a 0.8% hemoglobin A1C reduction after a year, 2.1% in the baseline group that was higher than 10, which would be to be expected. But in hyperlipidemia, nearly an 18 milligram per deciliter drop and a 15 millimeter drop in the hypertension. We analyzed this using the Archimedes model that we modified specifically for the VA. And looked at and evaluated outcomes at years 2, 3, 5, and 10. And what we were able to show in this manuscript is that for every dollar you invested in a clinical pharmacist, you got at least $2 return on investment in just some of these simple outcomes, but in some of the outcomes, it was much higher than that. So development of congestive heart failure, for example. But if you look at the overall cost, you had about $2 return for every dollar that you invested. Next slide, please. So one of the things people have asked us is, what is the model, or how do you use the model to compare time? So I wanted to be transparent and share this with you, because this is, we take VA salaries. We take those salaries are known to the public, so this is no surprise. We add our benefit package to it, and we come up with a cost per 30-minute encounter for a primary care physician, a pain specialist, a psychiatrist, and a clinical pharmacy practitioner. And so you can see that if a pharmacist spends the same amount of time treating diabetes for a given patient as a primary care provider, or a mental health pharmacist spends that time compared to a psychiatrist, there's a cost advantage to using the pharmacist. So as long as you can show that the outcomes are similar or better, then there's incentive to start moving some of that care away from the specialists that we often can't find. I'm sure most healthcare plans have a difficulty finding pain specialists and psychiatrists just as much as they do primary care doctors. One thing that's unique about pharmacy right at the time and at this moment is there is not a shortage of pharmacists. And the pharmacist profession is actually one of the few that don't have major shortages. So even though we have shortages of nurses, primary care docs, and specialist docs, we have pharmacists. So let's use them to the best of our ability. Next slide, please. So the other more interesting things that we've been working on in the last couple of years is, as part of these launching integration of clinical pharmacists into our primary care teams, into our specialty teams, we've also hired third-party investigators and researchers to ask questions about patient satisfaction, about provider satisfaction, about burnout, about integration into the team. So how did the other team members perceive the addition of a pharmacist into the team? Because I think, as Dr. Flynn mentioned earlier, you know, in the beginning, it's not always like, hey, yeah, come on in. You know, there's this fear that these new clinicians want to take their jobs or their role rather than being collaborative and helpful. And so we wanted to measure all kinds of different satisfaction of team integration. And so the first one I'm showing you here is patient satisfaction, because patient satisfaction is a key parameter that we measure in the VA, and we want to make sure that our customers are feeling like they're loved and they're understood and they're treated well. And then you can see here our mean overall satisfaction scores with our CPPs as providers is 90.6, which is very high scores. So overall satisfaction is high. Their satisfaction with their service, their knowledge, and their ability for self-management. So again, the references are down here if you want to investigate any of these in a little more detail. Next slide. So the other big thing is clinician satisfaction. So we really wanted to understand how does the rest of the healthcare team rate the pharmacists. And so 80% of responses rated the ability of the pharmacist to evaluate medication therapy and monitor the effectiveness as highly positive benefit. And probably no surprise to those that have worked with clinical pharmacists, especially those that are well-trained to do what they do, that the overall satisfaction has been positive. 87% of physicians and nurse practitioners responded to the CMM integration by clinical pharmacists that it decreased their time managing patients and improved their weight. So it improved access, and they felt it. They also felt that 93% of the physicians and nurse practitioners felt that the clinical pharmacist integration into the team improved their job satisfaction. This is so important in a time where physician and nurse shortages occur and we're having difficulty finding them. We want to keep the ones we have, and they're finding that team-based care does just that. Next slide. So going on with clinical satisfaction, this is just kind of additional data looking at some 496,000 patient encounters and interviews with 22 different clinicians and physicians, as well as nurses and other team care members. And basically what this study showed was that the pharmacists were well integrated into the team. All of the team members really valued their contributions to the team and significantly improved the medication use process matrix. And I'm sorry I don't have the matrix on the screen here, but I would encourage you to go look at this. And it's very interesting because, you know, the pharmacists, for example, rated themselves a little higher in their knowledge of medications than perhaps some of the other people, but they were all close. But one thing that was clear, that they all valued having them on the team, and they, after time, they realized where they could really leverage the pharmacists, especially in improving access and quality. Next slide. So provider work life, and I think all of you probably know this is a big issue right now, is assessing the impact of integration of the pharmacist into provider work life. Both primary care team members and the clinical pharmacy specialist or practitioner agreed on a high level of contributions in all 5 domains of the MUMP. And so again, well integrated. Findings from the interviews of all of these people, these are independent third-party interviews, felt that the pharmacists made substantial contributions to patient care and to the well-being of the team. And so this is an area where we want to try and continue to focus on is job satisfaction, because we know that job satisfaction reduces burnout, reduces staff turnover. Next slide, please. I want to mention a couple things outside of primary care, hypertension, hyperlipidemia, and I know the focus has always been on those areas, but we think that the clinical pharmacy practitioner has a huge role to play in many different areas, and where, especially areas where pharmacotherapy is prominent. And so one of those areas is pain. And so we have really, in the last 4 or 5 years, stepped up the scale and scaled up the training of our clinical pharmacy practitioners in pain. So one thing we recognized was there are not very many pain specialists out there. So there's not very many pain specialist physicians. There's hardly any pain specialist nurse practitioners. We had a lot of pharmacists who knew a lot about opioids, who knew a lot about non-steroidal anti-inflammatories. They knew a lot about the drugs, but they weren't comfortable, you know, being the person that managed the pain, especially in a primary care setting. And so we actually spent a lot of time scaling up the training of these teams. So what we did is we put together clinical boot camps to train up pharmacists specifically in these diseases I'm going to talk about right now. Pain management was one of those. And we've gone from a relatively few number of pain management encounters done by pharmacists to, in FY20, 129,000 patient encounters were done by a pharmacist. And this really, we have scaled the number of pharmacists that we had in the VA who were pain specialists. Was like 10 when we started this program. Now we have nearly 200 pain pharmacists in the system. And so we're really stepped up this treatment. And this has led to a realization that you can't really treat hypertension and diabetes and lipids and all the other disease states very well if patients have problems with their pain or their mental health. And so it has to be a whole health approach to be able to make this work most efficiently. So we've scaled up additionally, as it has some data on this slide, training of our pharmacists in substance use disorders. I'll show you a little bit of that data in a few minutes. And that includes alcohol use disorders as well as opioid use disorders, and really have tried to reach out to get those patients engaged and treated, because what we found is that patients are so focused on their mental health or their pain that they don't bother even taking their diabetes or hypertension drugs very well. So next slide. So this is the growth of our pain pharmacists. So we started some pain programs back in 2017, where you see what's called here our CRVA Legacy, which was a rural health grant that we got. We actually got about $100 million grant for 5 years to scale pharmacists across primary care practices. And part of those practices we scaled was pain management. And so, as you can see, we started with CRVA Legacy, then we had another project that we got funded through the Office of Rural Health, the substance use disorder, and then we're on to phase 3 now in 2022, what we call the diffusion phase. And you can see that we've scaled significant number of both encounters, the number of patients that have been reached, and the number of staff that we have to treat pain within the VA. And off to the right is the modalities we use. And so again, you can see phone is a big modality, as is VVC and other virtual modalities. Next slide. So we've also looked at mental health, and again, this has been a big focus of ours. Comprehensive medication management for depression, anxiety, PTSD, bipolar diseases, schizophrenia. These are patients, especially in the primary care setting, where they might have mild disease, but in the mental health setting, there isn't enough psychiatrists to take care of the patients. So we have usually PGY2 trained pharmacists that specialize in mental health, work in the psychiatry world, and they take care of the more difficult schizophrenia patients as well as more difficult bipolar patients. But between the two, as the model I described earlier, between the two primary care setting and a specialty setting, you can still hand the patient off pharmacist to pharmacist. Focus primarily on the comprehensive medication management piece. If there's additional diagnostics that need to be done, then of course we bring in the psychiatrists and other people. If there are things that have to be done that don't involve medications, which medications is not always the best choice for a lot of the mental health diseases, you know, we have to bring in the psychologists and the social workers to help the team get there. We've also targeted suicide risk assessment and have pharmacists really involved heavily in dispensing of naloxone and really trying to look at preventing opioid overdoses as well. Next slide. So this is our growth in mental health pharmacists. So I won't spend a lot of time on it, but it's a similar graphic. We've been able to really scale the use of CPPs to manage mental health. Next slide. And then, as I mentioned before, we have about 40% of our veterans would screen positive right now for AUD. The problem is we don't have enough people to treat these diseases. And so primary care docs and even the psychiatrists may not have the time to follow these patients, start alcohol use disorder drugs or opioid use disorders. And because you can see, we have over 40% of our patients in both groups that have this issue. So we've really scaled the use of our pharmacists here. Next slide, I'll show you some of the graphics. So again, we've scaled boot camps and trainings for these pharmacists, and now we're significantly starting to scale the number of patients that we're being able to take on for substance use disorders. Hopefully, when they get over their substance use disorders, a lot of the patients are homeless because they have substance use disorders. And if they're homeless and they have substance use disorders, they rarely get good treatment for their hypertension or their hyperlipidemia or their diabetes. And so this has to be a primary focus. Then go after the cardiovascular disease in this patient cohort. Next slide. And this is our AUD. So we're just starting to scale our AUD, but we're making some significant progress in alcohol use disorder as well. Next slide. So I also just want to point to that we've been trying to publish a lot of our work. I know I just skipped over some of the slides that I put here, but there's a lot of granularity to this data. There's a lot of well-structured researchers that we've partnered with who independently help us measure the impacts of pharmacist integration. And we believe that we have a body of data now and a whole bunch more coming out that really fundamentally will question why people do not integrate more clinical pharmacy specialists or practitioners into their practices, because the evidence has become overwhelming that they can improve the healthcare system, they can improve access, and they can improve quality, and they can reduce burnout and improve overall team and patient satisfaction. Next slide. We have a bibliography for CPP evidence. We do this for each of our areas of practice. We put together a bibliography so that people can see all the data. And so if you want to know about what data exists that demonstrates that clinical pharmacy practitioner can improve mental health, we have 50 articles that we've analyzed and put together in one particular package. Now, we use that internally right now, but these are things that we think are going to be strong tools for every practice area. Next slide. We did recently create a public-facing website because we've had a lot of requests to share our information, share our data, share what we're doing with developing our pharmacist workforce. How do we scale people up to be able to take on unmet needs? And so this website has just started only a few months back, but we're starting to populate it with our articles and data and other information. And these are all available through public access. So I share this. If you have questions about any of this, you could obviously email me individually, or we have an email there, Ask PBM CPPO, which is a clinical pharmacy practice office, and somebody will get back to you about the information. Next slide. So I think we have a poll that we are going to be doing on the post-test questions, and then we'll wrap up. All right, so which of the following statements are false about clinical pharmacy practitioners in the VA? They have more than doubled over the past decade. They represent more than 50% of VA's workforce. Their patient encounters now exceed 9 million. Their areas of involvement have expanded greatly beyond primary care, or none of the above statements are false. And you can vote on those, and I will read the second one. Which of the following areas of healthcare quadruple aim are impacted by VA clinical pharmacy practitioners? Access, quality, costs, provider satisfaction, or all of the above? And I hope you will all get these ones right. All right, well, if question number one, it looks like 83% got it right. None of the statements are false. They were all true statements. And then for number two, if we can scroll down, I can't see it right now, what the results of question two are. Well, I can't see it on the poll, but the answer is that all of the above are true statements about the impact of clinical pharmacists on healthcare. Next slide. All right, so that's what I have to present. I hope that's been helpful to just give you kind of a brief overview. We have a lot more that we've been working on. I didn't even mention things like antimicrobial stewardship and oncology and pharmacogenomics and neurology and all the other practice areas that we've really scaled up. But hopefully that gives you a sense of the work that we're doing, the types of research that we're doing, and we'll give you a sense of where we're going with integration of clinical pharmacy practitioners within the VA. Thank you.
What a wonderful presentation, really heartwarming. It's been a while, Dr. Morreale. It's great to have you back with us.
Thank you. Great to be
And
here.
I see we have a hand raised, which has disappeared. What? So Steve, did you raise your hand accidentally?
Yeah, I was trying to use the applause symbol and I hit the wrong button. Sorry.
Okay. Well, we have lots of people who are interested in being involved in this program and talking with our wonderful speakers here today. Steve Sidney in particular wanted to raise something when he's ready. And Steve, did you want to mention the similarities and differences with what Dr. Morreale was just saying?
Well, I wasn't here for most of the presentation. What I got from it was really excellent. I just wanted to give a report because I know it would be of interest. And I was asked about this the other day, is what does Kaiser Permanente do? So I'm a Permanente medical group, which means I'm a member of the physician group for Kaiser Permanente in Northern California, the entire region. I'm not a clinician, however, so I don't do the clinical work in it. I'm a research epidemiologist. I spoke today with Dr. Joe Young, who was recently retired, and just his last several years, he was the clinical hypertension lead for the entire region of the physician group of Northern California, and asked him the question about the role of pharmacists in hypertension treatment and control. So what he said is that it's not true in all the medical centers, but in quite a few of them. First of all, it's considered to be a best practice to have the pharmacist involved in hypertension management. And what limits it in some of the Kaiser Permanente facilities is budget and have an adequate number of pharmacists. But where they are available, the role is hypertension, blood pressure is measured at a Kaiser visit, and actually people can just walk in for a blood pressure check, which is done by a medical assistant. If there's a pharmacist available in the program or at that center, the medical assistant basically shoots the blood pressure over to the pharmacist, and then the pharmacist can make treatment adjustments without the physician being involved at all within basically an algorithmic program. So within various parameters, the pharmacist can increase, decrease dose, keep it the same, add a drug. And as long as it's within the guidelines and protocols that have been set for that, that is done directly by the pharmacist, and the physician, really has no involvement in that encounter. So that's basically what is done at Kaiser Permanente.
Thank you, Dr. Sidney. I think that Dr. Morreale's cost effectiveness slides were really, really mind-blowing. And I wonder if you just want to verbalize a little bit about that, Dr. Morreale, because it seems like we often hear health systems say, we can't afford to add the pharmacist, but I think your slides argue otherwise.
Yeah, I mean, I would argue we can't afford not to, because if you're saving money and you're improving care, why wouldn't you? Now, it does take an upfront investment, and I think that's where a lot of people struggle, is to try and get that upfront money. And I'm sure Steve's had the same experience, is once you get the money and you get the people in, at 1 year, they let you keep it. And in fact, when I was director at the VA San Diego, we scaled our clinical pharmacy program up tremendously. And every time I went to our leadership and our resource committee, I said, give me the money for 1 year. And if I don't save you 2 times, 3 times, 4 times the money, you could have the positions back. So you're not at risk for the long term. And I never gave a position back. I always came in at the end of that 1 year, showed them the data, and they always let me keep the positions. I did want to have one comment about the difference in the VA model compared to the Kaiser model. We don't, in the VA, we don't use protocols. We don't set limits on how the pharmacists practice. We want to make sure that our pharmacists are fully trained, competent, and as good at treating the disease that they're treating as anybody else would be. And we use the same quality assurance tools that we use for physicians or nurse practitioners. So they go through all of the same quality assurance assessments of their chart notes, of their cases. If a case has a bad outcome, they go through the same types of reviews as the physicians do. And so we don't really say, okay, you can only pick these drugs for these treatments. There are occasionally drugs that, from a formulary perspective, that might be restricted to a cardiologist or something like that. But in general, all of our treatments of our disease states, whether it's diabetes, hypertension, hyperlipidemia, and in fact, in primary care, we just say, you're a primary care pharmacist, you have a broad scope of practice. If you don't feel comfortable treating a given disease, then don't treat it. But if you feel comfortable and you're competent in doing that, then we're not going to put limits on you. So it's a little bit different structure, but we have seen that that has paid benefits all across the board, and we have not had any problems going through the peer review process. And we have a publication on that, just so you know, about peer review and quality, because we think it's very important that we're under the same rigor that the physicians and the nurse practitioners are under, because we know and we're confident that our pharmacists can do the same.
Well, I will chime in with a little teeny personal story, which is that I'm allergic to a lot of things, including a lot of medications. And one of my many famous coughs ago, I think everybody knows I have missed a few things with lung infections over time. I was prescribed an antibiotic that I'd never heard of before, and the doctor insisted that I take it. And I went into the pharmacist to pick it up, and the pharmacist said, no, you can't take that. You're allergic to that. It's the same class as the other thing that you reacted to. So I would have to say that because my reactions to antibiotics are very noteworthy and dangerous, I then tuned in to the importance of that person really understanding the medication, sometimes even better than the physicians. And I am personally grateful for the pharmacist intervening on my behalf. That worked out well. I could go on because we've been talking about this for a few years. I just want to ask if anyone else has questions for Dr. Morreale before
I see one question in the chat or in the Q&A about if you only have resources to hire, limited number of pharmacists, do you target a specific diagnosis? And that's a tough one because we don't have enough pharmacists even in our primary care settings. We're still deficient nationwide. We need 600 more, right? And that's to get the funding. You got to keep going through. From our perspective, we got to go to Congress, right? And I would just say the answer to that is to really assess where your needs are. Some people have really focused on bounce backs, for example, or recidivism of patients that might leave the hospital and then not get good transitions in care. Other people, if you're working in a primary care setting, you're looking at, who are the patients that are having them least control based on the quality assurance parameters. So it really varies a lot. And so from our perspective in a clinical pharmacy practice office, we look across the whole VA and say, what disease states are being poorly treated? And I know that, this group, Right Care, has been focused on hypertension, diabetes, and hyperlipidemia, rightfully so, because you have the QA parameters that say only 50% of your patients are controlled. Why don't you do something about that, right? So it's easy, low-hanging fruit to do that. It's more difficult to find patients that don't have pain control or other softer parameters that don't have, a laboratory test or a, some kind of biological test to do that. So, there are many, many ways to take this approach.
You can see a couple of raised hands, right, Dr. Morreale?
Yep.
So why don't we hear from Dr. Balmer and then Dr. Sidney?
So great presentation. I had one question, and that is, if we take a regular pharmacist trained and we train them then to become a pharmacy practitioner or pharmacist practitioner, how many hours, weeks, days, or years of additional training does that require to do that step up in learning for increased ability?
Yeah, so I guess it starts with, how do you define a regular pharmacist? As you probably know, most pharmacists since the early 2000s have graduated with a doctorate of pharmacy degree and have pretty good training in the basics of use of the medications. If they've been out of school for a long time, they may lose some of that, as we all know. If you have a pharmacist, let's say, that's just been working in a retail pharmacy, outpatient pharmacy setting for many years, may not have the skills to take on disease management right away. They may still have the residual understanding and skills around the drugs, because they've been counseling patients, they know the new drugs, they know the dosage forms and the like. And so if you're taking something very targeted, and I'll use examples of pain management, where you might have 25 drugs that you have to rescale or retrain people in, you might be able to get them to do, to have enough skills to do pain management in a primary care setting. So these are not your advanced pain patients. Within a 3 to 7 hour tutorials of training. But then you need to have somebody with them when they first start to make sure that they're treating the patients right? So you have a didactic education, then you're gonna have somebody with them to make sure they go through 10 cases, give you the reviews, those kind of things. And remember, these people are not working in a vacuum. They are working collaboratively with the physicians. And so they're coming to the physician and say, well, this is an easy case. This is what I'm thinking, based on my education and training. But there's still complex cases that you go to the provider and say, we have choices here, but it's complex. This is not an easy case. So you have to work together to be able to do that. If you want to go more broadly, like, developing a primary care pharmacist that can do 20 different diseases, then our boot camps that we run people through are usually, first of all, we have PharmDs with residency trained. Most of them are board certified. We only need to probably give them a week's worth of training because they're already starting at a really high baseline. The VA has hardly hired anybody but a PharmD with residency in the last 10 years. So it depends on who you hire. And we've taken the approach in the last 10 years, unless you're in like a really rural area and you need somebody to just dispense drugs in an outpatient pharmacy, that's fine. But the vast majority of our growth, in fact, almost all of our growth, has been CPPs. And so we need people with PharmDs and residencies and board certifications. Was there another hand up? No, we had a question.
Yes, Steve Sidney, go ahead.
Yes, I just wanted to add one point that I neglected to mention before in my discussion with Dr. Young. It's this issue about what what kinds of disorders or medical conditions the pharmacist is utilized in. And it's basically, according to him, it's diabetes and hypertension, with diabetes getting a little bit of a priority over hypertension if there's a scarcity of resources. I just wanted to add to that.
Yeah, and you know, that makes some sense. The way we look at it when people say, well, what should the CPPs doing? And I look at it and say, any disease that has a high pharmacotherapy burden, which means you got a lot of different drugs you could treat people with. The drugs require a lot of monitoring or titration. Those are perfect clinics to scale up the clinical pharmacist. If you have an area where they're simple drugs to use, one dose you start people on and you don't even need to titrate it, then you don't really need them in those kind of clinics. I see Dan Kudo had a question about, do you encourage board certification? And as I mentioned, Dan, we pretty much, I would just say we have encouraged it for years. We actually do training programs to train people to go take the board certification, and we actually give them raises when they get board certified. So yes, we've encouraged that heavily, but I think people have voted with their hires. I mean, we just don't see people being hired that don't have those kind of qualifications. So, when students ask me, should I do a residency? Should I get board certified? I said, depends if you want to work at the VA or not, because that's the kind of people we're hiring. And it doesn't mean you can't get a job in the VA if you don't have it, but your chances are much less.
We've had a wonderful discussion, and I think that we should transition to our next speakers. I hope, Tony, that you can stay with us.
Yes, I can.
Great. I'm sure that this conversation might go a little long. We're absolutely thrilled with the data that's been presented today. Dr. Flynn did introduce Steve Chen a bit earlier. Steve, I think the most efficient thing is, because we want to have lots of time for you to discuss your work with Jessica Abraham, is if you would just say a little thumbnail sketch about your amazing work at USC with the state, with the federal government, et cetera, then we can just jump right into your slides.
Okay. Actually, I think the intro was done before, so I'll just skip. Just the bottom line is, I think Anthony said it perfectly. He didn't mention actually that we know each other going back maybe 25 years, Anthony, right? Way back when I was still in the VA system. I spent about 10 years there. What a great job you did covering the amazing health system of the VA that you work in. I love my time in the VA. I trained in the VA. And he's absolutely correct. I've sort of, my mission after leaving the VA was trying to take all of the benefits that pharmacists bring in that setting into the outside world. So let's just leave it at that. I'm happy to move on to this presentation.
Well, you're welcome back anytime you want to come.
Thanks. I'm trying to steal you out so you can help us. I do want to take a minute to introduce Jessica Abraham. When Dr. Flynn said there are two presenters, he really meant the two that matter, Dr. Morreale and Dr. Abraham. Dr. Abraham is our Director of Population Health at the USC School of Pharmacy. She has had prior experience as both a very high impact primary care clinician and working in health plans. So she's got really all kinds of perspective and experience to bring. She directs a fantastic virtual pharmacist care center program here at USC, produces great results, and she's instrumental in all the work we do in comprehensive medication management and spreading our work through the California Right Meds Collaborative. So she'll be co-presenting with me. Okay, now I'm going to share screen. You can all see, I assume. Okay, great. So yeah, moving forward as quickly as I can now, this is what we're going to cover in our time left. Just a brief update on the state of the evidence, which is the title of the seminar today. And then we'll talk about exactly what Dr. Morreale said, which is trying to take comprehensive medication management outside of closed health systems in our work at the California Right Meds Collaborative and our next steps moving forward. I need to apologize also in advance to about maybe a dozen or so of you that were on the Healthy Hearts conference this morning, because you're going to see a lot of the same slides. And again, I think Anthony framed it so well. Medication-related harm is an epidemic. And it actually angers and frustrates me that we allow this to happen, right? We talk about, well, pharmacists shouldn't be in this space because of scope, because of financial issues. And at the end of the day, people die. People are harmed because we don't get medications right. The amount of money, over $500 billion, fourth leading cause of death, 10 people die every hour in the US. These are things that we shouldn't be accepting. And if pharmacists didn't add value in this space, I would never promote it. But I've now practiced in the VA, Skid Row, Cedars-Sinai, Beverly Hills. It doesn't matter what insurance you have. There is an epidemic of medication-related harm that's occurring in our country. And I think, again, Anthony covered it very well. Comprehensive medication management is the standard of care. And he also mentioned, which I agree with, it's not for every patient, right? You're supposed to direct this to patients who have the greatest potential in terms of risk or emerging risk for either advancement of chronic disease or harm from medication therapies. It's about choosing the right medication, giving the wide array of choices out there, getting the dose correct, not so low it does nothing, not so high it does too much. Classic example, the not high enough dose are, I think you see it a lot as well. In primary care settings, we see antidepressants being given at doses that are starting doses that are not therapeutic, and they never move from there, things like that. Don't make much sense. Making sure that given the other medications and other conditions, that there are no drug interactions that are harmful to the patient. Making sure patients can use medications and medication-related devices, and making sure they're affordable. And all of this is wrapped into evaluating all conditions, all medications, and following up with the patient and driving them to their treatment goals. There were some really good questions that came up during the previous presentation. Among them, things like, are there any conditions, when you say any, are you talking about all conditions? Yeah, I agree with what Anthony said. We are talking about all conditions that have a high treatment burden or treatment element in terms of getting successful control. The exceptions would be things like you wouldn't want a general primary care CMM pharmacist to be involved in too much oncology or very complex mental health, right? These are some areas where we don't generally include, but really it's just about anything else apart from that. And if this helps, I try to share this with people that are new to the idea of pharmacists in this space. You have this pyramid of population health domains. And as you go up the pyramid, you have a higher direct cost savings or cost avoidance for payers, and a more rapid rate of return on investment when you invest in these populations. And at the very top, you see high risk, high utilizing patients, meaning high utilizers of healthcare resources. And then right after that, emerging risk for disease control. These are areas that are ripe for comprehensive medication management. And if you look at what percentage of patients are we talking about in a given population of care, in a non-senior population, somewhere in the neighborhood of 15, 20, up to 25% of patients would fit into these categories that would benefit from comprehensive medication management. And then, just below that, you have your regulatory measures and HEDIS and QF, that sort of thing, they're usually done with more one and done type of check-ins with pharmacists. And at the very bottom, the very important preventative health interventions that pharmacists can make in a variety of settings, including outpatient pharmacies. And as Anthony has said, I'm so glad you went first, Anthony. You covered so much that I don't have to talk too much about. There is, as you said, an abundance of evidence that supports the value of pharmacists in this space. And everything you see here is not a pharmacist-centric or pharmacist-published document. It came from other healthcare disciplines or other organizations that were not pharmacy-centric. So that at least the point is that there are plenty of healthcare professionals that advocate for this, that want it. It isn't a question of want, of value when someone gets a chance to experience, working with a pharmacist in this capacity. The challenge outside the VA, I would say there are many, but one of them is that it's the misalignment of incentives. It's the fragmentation we have in our healthcare system. Anthony had shared that he's able to get funding for a year to be able to show return on investment. That's basically what health plans want, right? Health plans, in order to fund something, generally say, I want to see an ROI, within a year, because that my patients may leave my plan and go somewhere else. So it is a great challenge to launch this in a system outside of a closed healthcare system like Kaiser or VA. I'll start off by just recapping that Hattie Hanley has led a variety of briefings that are very helpful in summarizing the key evidence to support different priorities. And among them is the Pharmacists and the Care Team briefing that is now about to go into its third edition. This is the 2018 document that summarizes some of the important trials across the nation that have demonstrated high value from having pharmacists on the care team. So things that we've heard of through our partners in Right Care, like the barbershop program run by the Dr. Ron Victor out of Cedars-Sinai, the work out of Hawaii with the Medicare program, CMMI program that was led over there, Health Partners in Minnesota. So if you haven't looked at this, I think it's been archived. So we're trying to quickly update it so you can get an updated version of it. But I'm going to talk about just a few of the studies that we're going to include in the updated document. So one of them is based on some work that was done by Dr. Karen Margolis and presented here back, I think, a year and a half ago in Right Care. Dr. Margolis led a hypertension management program for high-risk patients where telemonitoring and medication management was conducted by pharmacists. And this is what it looked like. You can see that the pharmacist had maybe the first visit face-to-face and everything else by telephone throughout the intervention program for these patients and managing their high blood pressure. And this is the average systolic blood pressure reductions that occurred in the first 12 months of this program. And you can see that in most cases, within 3 months, patients were at their goal. And you can see why in this slide, where the intensification of drug therapy occurred very quickly in the first couple of months or so, and then sort of trailed off after that. So it proved to be very effective. These are the patients that they looked at. Just a quick summary of them. And when you considered when you looked at the 5-year follow-up article, which followed the original article talking about the paper and the impact on blood pressure itself, you can see if you look at the very bottom that there were 50% less cardiovascular events that occurred in the intervention group versus the user care cohort. And she attempted to translate that into what the cost savings would be. You can see that the net savings was just over $1,200 per patient in the intervention versus the control group. So really impressive work out of Minnesota. And I think what I didn't show is the dashboard they used to manage hypertension. It was very well done. Reminded me very much of the similar quality improvement work that Dr. Ron Victor did with his barbershop program. Another paper we're going to include is actually from right here in Southern California. This is work done out of Inland Empire Health Plan. This was, I would say, wasn't full comprehensive medication management, but it was close. Everything was done remotely by phone, so no face-to-face. They didn't have collaborative practice agreements, so much of the interventions had to be done by recommendations, but they managed to provide some pretty impressive results. You can see that in this study of 2,000 or so patients, the mean average number of medications per patient was 25 for 10 conditions. So these are patients on a lot of different medications. And they were mostly, if you look at the age group, on the older side, 40 to 64 was the main age group that was enrolled, so mainly Medicaid recipients. And this is what they were able to alter or modify in terms of medication-related problems. They had 7,500 interventions with 46,000 recommended actions. And you can see what these actions are in the bullet points below. The medication actions were discontinuations of therapy, order refills, simple as that, replacements, and then general actions, updating labs, updating medication lists, that sort of thing. So it didn't seem like it was extremely complicated in terms of the med-related problems they identified and resolved. But when they looked at real costs from the health plan, not projected, but real costs over time, they found that there appeared to be a $14 million annual savings associated with this program for those 2,000 members for a 12.4 to 1 return on investment. And then another article, I think there are actually people on this call that were part of this work here, was looking at this transitions of care service in Kern County, California, that was run between pharmacists who are embedded in a medical group working with pharmacists that are out in the community. And this is, and I'm sorry there's so much detail, but I just want to give you a good summary as to who they actually enrolled in this program. There were a lot of patients in this program, thousands, in fact, I think over 10,000 to begin with. And you can see that The average age was older. This is a Medicare population, 67. Many health plans represented. Average length of stay in these patients was generally 1 to 7 days. You can see it was all seasons during the year, so no predominant season. And very importantly, I wanted to show you that there were all sorts of conditions that were the primary reason for hospitalization that were included in this analysis. And what they found was that having the pharmacists embedded in the medical groups, working with the pharmacists in the community to manage medication-related problems, to coordinate refills and make sure patients got the right medications and knew what they were doing, resulted in a 41% less likelihood of being readmitted within 30 days versus usual care. And then at the 180-day mark, it was 18% less likely to be readmitted. In a similar study of Medicaid populations published, I think about a year earlier with the same group, they found 28 and 32% respectively reductions in likelihood of readmission. So again, those are a few of the studies that we're going to be including in the update on the pharmacist and the care team briefing. So with that, I thought we'd spend a little bit of time talking about exactly the challenge that Dr. Morreale presented, which is, how do you take something in a closed health system that works well, that where you have all the metrics, all the information available to you, and make it work out in the real world? And so many challenges that we face in this. So I'm going to share the evolution and progress of the California Right Meds Collaborative, which, if you don't already know, is basically an attempt to create a network of pharmacists in the community that can offer comprehensive medication management locally to the communities that they serve. And this came about because when we finished our Center for Medicare and Medicaid Innovation, Healthcare Innovation Award with Ultimate Health Services, where we had pharmacists embedded in their clinics and we had a video telehealth program on top of that, we had the kinds of results that Anthony had shared, really good impact on cost, quality, safety, access, satisfaction across the board. And we thought, this is great. CMS is going to now open the floodgates and pay pharmacists to do this. And of course, that was never the intent. It was basically giving everyone a shot at, or the grantees a shot at demonstrating value, but then the grantees would have to figure out how to sustain it. So we went right to payers this time, and we said, look, it's great that we can work with one health system at a time to implement CMM, but let's go right to the payer and find out if there's a way that we can make it work where they would be interested in supporting this work for the benefit of their patients and for their own bottom line. And the short answer as we approach payers was, we're interested, but we don't own clinics. We don't have sites of care. What's the solution for that? And that's why the community pharmacy idea came to being. And then almost just as importantly, we understand that payers don't want to pay fee for service, nor really should they. They should be paying for value. So based on our work in our CMMI grant, we came up with a framework for a value-based payment model that's been adopted by our health plan partners. So again, kind of a no-brainer. Some of you have seen this slide before, but there are 4 times more pharmacies than Starbucks across the nation. That's a lot of access. And you think about it, it's a shame that we have so many of these pharmacies that are pretty disconnected from the rest of the healthcare system. This is something that we should be leveraging. So not only is there not a shortage of pharmacists, there's not a shortage of locations and communities where people can get access to a pharmacist. And they do. You can see here that seniors set foot in pharmacists an average of once a month at least, and Medicaid age patients 2 to 3 times a month. That's a lot of face time, a lot of opportunity to interface with these patients. So, part of the way we do this, and Bill, your question about training, I think it's a really important one, is we put pharmacists that qualify to be in this program in a very rigorous training program. Basically, it's the Institute for Healthcare Improvement's Breakthrough Series Collaborative Process. It involves at least annual live learning sessions where we intensively train them on key aspects of delivering CMM. We share best practices with them. We have breakouts for different levels of CMM capability to advance them to the next level. It's very rigorous. And to answer your question, how long does it take to take a pharmacist who generally has not done a lot of clinical work to become a CMM pharmacist? In our estimation, it takes 6 months of very rigorous training. And it's not just this, it's all this too. Meaning we have webinars, we have additional live trainings with patient actors. They have to demonstrate that they can actually deliver the care that we're trying to impart on them. And And then they're not done, right? Even after that rigorous 6 months of training, they're continually in a very granular continuous quality improvement program where we are tracking not just process metrics, but process metrics temporally to make sure that they're moving patients along in terms of attaining their disease state goals. So again, not just training, but training with feedback constantly. And we found that by doing this, within a year's time, these pharmacists are producing results that are just as good as pharmacists that have been residency trained. And again, we've seen that in our own collaborative. Quick picture of what this looks like. Health plans are identifying patients, stratifying from high to low risk. We are working with them to develop these networks of pharmacies that are highly trained, that are quality improvement to death, to make sure that they're producing great results. Health plans send the high-risk patients out to the pharmacist for enrollment. And we have schools of pharmacies and other partners that are working with these pharmacies to help ensure that they deliver top quality care. And with that brief background, I'm going to have Dr. Abraham give us an update on the Cal Right Meds Collaborative and where we are to date.
All right. So I'll just give a quick update of what we've done really since, especially over the last 10 months, but overall, really thanks to Cal Right Meds Collaborative that was founded by Steve and all the great work that he's doing with increasing access to care to patients in our communities. So next slide, Steve. So I'm going to do a little bit about just all our CRMC partners and how we develop them and continue to grow those partnerships for the collaborative. And then I'll just dig a little bit deeper into LA Care and Inland Empire Health Plan, who are kind of our pilot health plans that we started with and who have really become the pioneers in showing great results that have helped them move out of pilot phase and expand, and have also helped us in leveraging other partnerships with other health plans that we're onboarding this year. And then I'll end with our most recent work that has been around coming up with a better data platform to help really make the work very efficient and provide this continuous quality improvement. Next slide. So as mentioned, really CRMC is not just the pharmacies providing the services. They are definitely the significant integral partner, but it's the health plans, it is the local, state, national entities. It's all the universities who want to be involved both locally, nationally, and even most recently, you'll see internationally, we've even gotten some interest in, how do we do this in other countries in the world? Also recognizing the training and the ability and capacity that their pharmacists have in increasing access to care. And then of course, our pharmacies providing this care. So with our partners, we're constantly, growing that list, and they've all been very, very supportive and helpful in doing what they can, whether it's at a state level or national level, in expanding this work and supporting the work. Next slide. So for our pharmacies, as Steve mentioned, we have very, very frequent trainings, meetings, et cetera, with them. So for our pharmacies, we kind of have two sets of different meetings that we have with them. We have our meetings that are health plan, the pharmacy, and USC. And when we first started, we were meeting them weekly and providing things like just a pharmacy check-in, one-on-one coaching, seeing, because they're just starting something that they may have not had a lot of experience doing previously, checking in to see, do they have, the workflows, doing, continuous PDSA cycles, and making sure that we help them improve and provide them all the resources as a university, as USC, kind of really being that resource and training hub to help them make sure that they have the right resources in place to perform well. And what you're seeing here is a sample report card, and that was being given to them weekly. Now it's transitioned to biweekly and monthly, but as we bring more sites on and newer pharmacies, we always kind of adapt to what's needed. Some pharmacies need more and some need less, but what you can see here is they're getting a very, very detailed snapshot of exactly how they're doing with respect to their medication-related problems. How many are they seeing? Are they seeing any? The reduction in blood pressure, A1C, across how many visits, et cetera. So the pharmacies get to see this and they see it in a blind data report card. So they can also see how other pharmacies providing the same type of service with the same background and experience are also doing. And the health plans get to see this so they can see everything across all pharmacies or dig deeper into an individual pharmacy. So there's very strong element of continuous quality improvement. And we have a QI coordinator at USC and who's doing this really for the pilot sites being LA Care and now Inland Empire. And then as we grow, that team hopefully will grow as well, whether it's from USC or the health plans. But this piece is integral because we want to make sure that increasing access to care and allowing more pharmacies to provide this kind of care, that it's in fact impactful care that's making a difference right from the start and isn't really taking dollars and not providing value. Along with that, just really quickly, we also have our pharmacy network forum meetings, which are monthly, and these are the ones that Steve talked about with the all teach, all learn. So this is not just one health plan and one pharmacy, but all the pharmacies and all the health plans coming together. And the disease focuses might be different because the gaps with different health plans might be different, but it's really an opportunity for everyone to learn from each other. And that's where we do case conferences, journal clubs. And again, it's a very frequent recurrence to ensure that everyone feels very confident with the types of services they're providing. Next slide. Along with the pharmacy meetings, we have health plan meetings. So USC meets with the specific health plans in the collaborative. Currently it's bi-weekly, it used to be weekly. And again, there's a constant evaluation of, how is CMM through CRMC doing for their pharmacies? Are we meeting the gaps and needs that the health plan had? Are the pharmacies, attaining the outcomes that are needed for the health plan to be able to take this to leadership and expand the program and really, use these results as ammunition for expanding pharmacists, payments for services across various communities. We're constantly doing this with our current health plans and new health plans that are speaking to us this year about joining CRMC, and then other stakeholders. So Steve will speak a little bit about this, but not only have we seen the health plans interested, but now other initiatives, whether it's an initiative to increase care for homeless populations or specific medical groups and FQHCs who hear about this and want the service, and they want to know, which health plan will cover the service for us because we do have a need. We have these patients who are not seen as frequently as they should be seen. We had a physician who said, there's no way I can get through my 30, 40 patients a day. I do need a pharmacist on my team. What health plan would help support this financially? And those are some of the other ways that we expand CRMC to those groups as well. Next slide. And then the other initiatives, I already mentioned these. So right here, you could just see, for the pilot, and I think Steve actually has already presented this before, the slide you would have seen, it was literally half of this prior to 2022. So just in 2022, LA Care was able to more than double the number of pharmacies in this program because of the results that you're about to see through California Right Meds Collaborative and their LA Care network pharmacies. Next slide. And for their clinic partnership, so they actually started with just pharmacies providing the care to patients, but in trying to deal with that fragmentation of care that Steve was talking about, when a pharmacy had a great number of patients who were all kind of assigned to different physicians all over the place, different EHRs, no CPAs in place. Something that LA Care and USC discussed was, why don't we try to connect the pharmacies to FQHCs or other medical groups within the geography that have a larger patient population that need this, to kind of help grow that relationship between the pharmacists in the community with medical group leadership in their geography, so that that management of patients can really be done as part of that team, that interdisciplinary team model, versus more fragmented with these pharmacists managing all these different patients of all these different physicians who might not have stronger close relationships with them. So these are some of the clinic partnerships alone that LA Care has been able to come up with and establish in the last year. Next slide. So the results that kind of move them from being pilot to really running with this program. They started with an enrollment proxy of A1C over 9. Since then, actually this year in 2022, they've already expanded this to include other high-risk groups, so a diabetes cohort, in addition to that, a CVD cohort, and adherence and MTM cohort. So these are members who have uncontrolled diabetes, but also fall into those well-known Medicare measures for needing adherence to their diabetes meds, hypertension, lipids. And now they're also diving into a behavioral health cohort. So the health plan did so well that it was able to expand eligibility and really open it up to greater patient populations this 2022 year. And in this pilot phase of having patients over A1C over 9, they looked at diabetes control, so A1C under 8, blood pressure control under 140 over 90, and initiating a statin if clinically indicated and not contraindicated. And the results you're about to see were really just over about 5 months of program operation, when we know in fact that in most even closed systems, when a pharmacist is managing very uncontrolled diabetes, it takes on average anywhere from 8 to 9 months. So these results were really impactful. Next slide. So with 354 Medi-Cal patients, and there is a focus on reducing health disparities. So you'll see 51% in the Antelope Valley in South LA, and 29% self-identified as Black or African American. And I had mentioned already that there were 15 community pharmacies thus far, 7 or 8 clinic partners, and the average age was about 53 years old with 45% male. And in this population, we saw, next slide, the average A1C drop was about 2.4 points with a baseline A1C of 11.5. So just in 5 months, by having our community pharmacies out in the community who really never had done this before, but got robust training from USC in this continuous quality improvement, we saw an A1C drop of of 2.4%, blood pressure, systolic blood pressure drop of 18 millimeters mercury for patients who initially had a blood pressure above 140 over 90. Statin utilization more than doubled for this patient population. Pretty much 90% of the patients that were being seen by these community pharmacies were put on a statin if they had diabetes. And then, of course, this ongoing rigorous impact analysis was being done. So what you saw in that report card was being done. And most recently, we have a data physician, researcher, and a data analyst, pharmacist who are also brought on the team. And what they'll do is take these results and compare them to a control group so that we can get, more robust analysis to really show, okay, if we take it and compare it to control, what do we see versus just the intervention group. So next slide. So along with LA Care, we also kind of were concurrently starting with Inland Empire Health Plan. They started a little bit later, but to the point of, I think there were several questions about which disease state do you hit. For LA Care, diabetes was super important, and that's where they wanted to start. For Inland Empire, it was asthma. So they, this is their list of pharmacies, and which is also expanding, similar to LA Care. Next slide. And what they did was they enrolled 156 Medi-Cal members, and the criteria to identify them was based on the Johns Hopkins Adjusted Clinical Group scoring, where they chose high or rising risk members with asthma. These members were located in Riverside and San Bernardino County, and they tried to identify patients who are living close to that geography of a given pharmacy. And then they looked at the asthma medication ratio and reducing urgent care and hospitalization use to consider the patient, to look at their value-based payment model and whether they should be receiving the payments and the bonus at the end for meeting goals. So the next slide here will show you. So just looking at asthma now, something completely different than diabetes, you saw that just over 3 visits per member at these community pharmacies receiving asthma management. You could see that you had the well-controlled groups in green more than doubled. And then you have, of course, the decrease of the not well-controlled and poorly controlled member populations. So again, with this data, Inland Empire was able to expand their disease states. And this year they're working on expanding to blood pressure control, because that's really the next thing that's on their list. It's really, they've been wanting to expand to that since last year, but contractual things that make things take longer. But aside from that, they've already seen the results that their leadership has needed to see to continue to expand this to other disease states. And the same as with LA Care, there's an ongoing rigorous impact analysis to take this patient population and compare it to a control group. Next slide. So with the work that Inland Empire was doing for asthma, we were also able to get another opportunity through the cardiovascular disease prevention program from CDPH. And that was a program that we're getting ready to launch. We've kind of surpassed the IRB submissions and all of those things. And it's to evaluate the effectiveness of CMM services on clinical and behavioral outcomes in hospital discharged stroke patients, such as controlling high blood pressure. So the goal is to improve post-stroke high blood pressure control through CMM services. So if you give these patients, provide them with CMM services when they're discharged due to being there for stroke, the goal is to see that blood pressure control attained and prevention of a readmission. So that's a program that we're just about to launch. And again, it'll be through June of 2023. And it's to look at, again, pharmacies out in the community providing this type of work. Next slide. So the last thing I quickly will sum up with is data platform. So just as we're trying to always do continuous quality improvement for the pharmacies and how they're doing with these patients, we're trying to do the same for California Right Meds Collaborative. One of those things that Steve mentioned was, fragmented EHRs and everyone documenting somewhere different. So one of the things that's critically important is for all of our community pharmacy teams to document in the same platform. So with that, we initially had built something pretty simple to kind of collect all the data. And most recently, we transitioned to a company called Arene, which is really has a lot of artificial intelligence built into it. It's a data aggregation company to allow things like auto population of information from health plans, from FQHCs, from the pharmacies, really provide kind of a two-way data feed. And then a very robust clinical reporting and analytical tools to really optimize the capabilities of the QI coordinator and capabilities of pharmacists when they're documenting and providing that care. So that's kind of the latest thing we just did. We transitioned in January, and we're in that constant evaluation process and quality improvement and making sure that we provide the best resources and tools available to our community pharmacies. With that, I'll hand it back to you, Steve.
Thanks, Jessica. I know we're running short on time, so I'll just wrap up as quickly as I can. Where are we headed next? As Jessica had mentioned, our partners are moving from a pilot phase to a scale-up phase. LA Care is trying to get each of those pharmacies an enrollment size of 200, 250 patients or so. And that'll be enough to sustain a full-time pharmacist and full-time technician dedicated to this work. Because we know that when you give a pharmacy a partial load of patients, they're never going to be able to pull pharmacists away from the dispensing line to provide clinical care. And the advantage of giving enough business so they can have full-time pharmacists dedicated is, as Anthony said, you can go out and now hire pharmacists that are already trained, that are residency trained to do this. So that's something we hope to move pretty quickly. And my mental health roots in the VA have served me well. I recognize without question that we don't address the issues of top concern for patients. We're never going to get their primary care disease under control. So we have a parallel collaborative, the Psychiatry for Population Health Pharmacists Collaborative, that has been infused into this work to train pharmacists on how to provide basic psych medication management services in the course of CMM, and just as importantly, recognize when patients need more advanced care and connect them to that care. We have health plan partners that we have reached out to that we're about to work with. I saw many Blue Shield people on the call, Blue Shield being one of them, really excited for that. Both RightCare and CDPH have been instrumental in making those connections for us. Thanks to the California Chronic Care Coalition and California Pharmacists Association, we were able to get in conversation with Covered California. We are now listed as a vendor in their 2023 benefit refresh strategy. And next up, we're meeting with Covered California leadership to figure out ways to incentivize plans to participate in Cal Right Meds. And then Healthcare in Action is something a little different. This is a street medicine program out of Scan Group Health Plan that's payer agnostic, run by Dr. Michael Hochman. It's led by a nurse practitioner, PA, a social worker, and 3 peer navigators, which are basically formerly homeless individuals. These teams take care of 125 patients each. And the vision is that these teams will go out to a given homeless encampment area and provide services for a half day a week. The value proposition on this is the typical patient they're enrolling in this program has medical costs, believe it or not, of about $65,000 a year. and the care for this will cost $10,000 over the 6-month intervention period. And so the question came up, how can we add pharmacists to this program and make it make sense financially? Very different from the other CMM work that we've been involved with. And this is sort of what we've come up with together. They're recruiting pharmacists now through us that would provide limited supply pre-packs of medications the teams can pick up and deliver from those pharmacies. They would pay the pharmacist to be out with their team, providing CMM that half day a week they're in that area. And then the other 6.5 days a week, that pharmacy becomes sort of a medical home for the patient, where they can get further follow-up care, they can get long-acting injectable antipsychotics, other directly observed therapies, other services. And then the revenue for the pharmacy would be what you see here, the Medi-Cal dispensing fees, payments for CMM, stipend for being on site with a team, and the LAI administration. So if you know of any pharmacies in these areas located in the bottom, connect them to us. We're looking for them right now. And with that, just have a summary, value summary of comprehensive medication management, the value to each stakeholder, patients, frontline providers, and health plans. So Hattie, I think we can turn it over to you for questions.
Such an action-packed program and wonderful participation among many of our leaders who have managed to join us despite multiple conflicts. I wonder, we have a couple of people from Kaiser with us that we haven't met yet. Lynn de Guzman, can you come on video? Good. Okay, so we just want to meet you here and get you involved in the conversation. So thank you, Rebecca Cupp, for introducing us and bringing your new colleague to our attention. So how about if you just tell us a few words about how your program compares to what Steve and Anthony were just talking about?
Yes. Hi. Thank you. Hi. Yes, I'm Lynn de Guzman. I'm a clinical pharmacy services director here at Kaiser. And I think we do a lot of the great stories and work that you do here as well. So definitely really trying to train, or actually even trying to utilize our outpatient pharmacists, our community pharmacists, and really training them as well to get into the medication therapy management space to provide comprehensive medication reviews. Our team has definitely launched deprescribing programs. So really trying to find opportunities to stop medications or reduce the use of medications in chronic conditions. So some of our initiatives are with diabetes, hypertension, and nonsteroidals. In May of 2020, in Northern California, we did launch a mental health program also. So we are managing patients with mild to moderate depression and generalized anxiety, and do have a subset of specialized psychiatric pharmacists who are managing bipolar disorder. So just a lot of opportunities that we are also finding, and just excited to hear that all of these services with pharmacists are being spread to just around our community. So thanks for sharing that story. I know we only have a couple minutes, so that's just kind of a breath of what we're doing here also at Kaiser. So thank you.
I see that we have a couple questions in the Q&A. I think Steve and Anthony, you can look at those directly.
Oh, they're both from Danny. Yeah, do you want to go first, Anthony? Oh no, I'm sorry. You already asked that one.
Yeah, I already answered that.
Okay, sorry. Yeah.
You're up.
Okay. Yeah. So the question is, do we see value-based reimbursement for farms? I think for the whole healthcare system, if we don't, we will see more value-based reimbursement. It's the only way forward. It's the only incentive we have, right, to drive quality and outcomes. Fee-for-service is just not going to get it done. So in our other conversations with payers, I think that's the only reason why we've been able to gain their interest, is because we approach this from a value-based payment approach. And in fact, the model for our own program is somewhat value-based. So we're only successful if our teams are successful in growing this program. So yeah, absolutely.
So it's been really exciting to see over the course of the Right Care Initiative how many groups were skeptical, weren't adding the pharmacists to the care team, and how centrally important the major high-performing health systems have now come to include the pharmacists. So I have to congratulate the profession. And also, I'd like to hear more from Dr. Baumer. We did have a question somebody posed to about UC Davis about how they're able to start growing that.
Well, quickly to answer that, takes about a year or two to get all of the pegs lined up so that you can introduce a program like that. Half of our funding to start it was actually through a grant. So half of it was through a grant. The second half was through a budgetary line item that we put into our rehab, our cardiac rehab program. So it's going to be half submitted or half supported by budget line item in cardiac rehab, which we hope will eventually pay off, and the other half by a grant. And as we progress, it's possible that, both of those, if we show the cost effectiveness of it, could achieve coverage by the healthcare system because it potentially would save money, especially if we go to a value-based program as well. So that's a big incentive for it. So that's the process that we're using, but there are many other opportunities. And I believe that Steve's data and the cost effectiveness that you showed on those slides could be used by different healthcare systems to, let's say, get by the administration and to get their support for it. And I agree with Steve. The easiest thing is, and Morreale, that the easiest thing is to say, give us the funding for 1 year, and at 1 year we'll accept whatever the results are. And typically those results are positive enough that there's no further questions, after that first year. So that's, I think, a good approach for administrators who are a little timid to, let's say, put their toe in the water on a new program because they've got so many concerns to deal with. To offer them a temporary pilot program is a good idea for it. And then I had one additional question for both of the speakers, and that is, as we prepare to bring in a pharmacist, what type of panel size should I consider for that pharmacist? How many patients would that pharmacist routinely cover? And I expect there's a range. In other words, if they're handling only the very high risk complicated patients, it's got to be a smaller sample size. Whereas if they're treating hypertension, which hopefully in the first 6 months can get under control, and then it can be stable hypertension, and then only maybe need a check once a year or something, it could be a much larger panel. So what would be the range of panels we might expect for the pharmacist we hire?
Anthony, you want to start?
Sure. I would say in our primary care setting, we established, and I showed you on the slide, that we established one pharmacist, full-time pharmacist for every 3,600 patients. And you're right, when a pharmacist takes on a patient, one of the key things that we have is that you don't maintain a panel. Unlike the physicians who would take a panel of patients and they would hold on to those patients, they send them to the pharmacist and they have them, they get them tuned up and they send them back. And now that slot is open for another patient. Now, occasionally that patient's going to bounce back and the primary care doc's going to say, hey, I still need you to relook at this patient. But one of the challenges we had in the beginning was to get pharmacists to send the patient back, because oftentimes the patient wanted to stay with the pharmacist and the pharmacists want to keep their patient, and we're like, no, but this guy has a hemoglobin A1C of 7. Why are you keeping him in your panel, right? So we've had to really get people to think about things a little bit differently. When we talk about pain management, it is a whole different game. Those patients or mental health, we don't have a 3,600 to 1 ratio. You know, you're talking more like 1,500 to 1, and even less depending if you got schizophrenic patients or the like. So it has to be dependent on the practice area. But I think the key thing is, in a collaborative practice, you're there to manage that patient's comprehensive medication management, get them tuned up, and send them back to the provider to do the maintenance. And you free up that slot again, because that is the way you're going to be most efficient and most cost efficient for the healthcare system.
Yeah, and in our experience, it's somewhere an active enrollment number of 250, 350, plus or minus. There's definitely some wiggle room based on what Anthony said. If it's somebody who's relatively simpler, purely hypertension and a coag, you can up the numbers. But if it's heart failure, it's some of these very high maintenance patients, it's definitely being on the lower end. And on our side, our experience has been, we try to do exactly what you said, Anthony, hand back to the primary care provider for maintenance once patients are at goal. Somehow it doesn't quite happen, right? They bounce back to us. And so now we've trained our pharmacy technicians to do check-ins every few months. Again, yes, no questions, collecting numbers. And basically the pharmacist gets a chance to look at that and make sure that things are on track still. If they're not, they'll get re-enrolled into our program.
And I will say, for anticoagulation, that's totally different. I mean, we keep the people for life.
Yeah.
And so they stay in the program. But for most of the areas where they just need a tune-up of their, whether it's COPD, CHF, hypertension, hyperlipidemia, once they get to goal, you're not going to change their pharmacotherapy very often. And you've already accomplished the reduction in the improvement in access for the providers. So there's really not a driving need to continue to do that.
I have a question
Go ahead.
for all of the panelists. As we advance, hopefully advance the role of the pharmacist and the care team and try to pivot the patients back to their physicians, because of what Jessica was talking about, the fragmentation of care and how these new methods of data aggregation are coming into place, I think it will be key for the practitioners who get these patients back to have a way where they can aggregate the data, know what medications have been tried and failed, which medications the patient has been, successful with, and how do we display this information to the practitioner so that we're not standing there back to square one after all that beautiful work that you all do or did and achieved?
Well, I will just say, and then I'll let Steve take this one because it's complex outside the VA. We have one giant electronic medical record system, although we are moving to Cerner, which is a whole different discussion going on. But we have one EMR. We have lots of clinical dashboards that we've created that help the teams identify those patients that are at risk, those patients that are not at goal, and allows the pharmacist to get those patients back to goal. Once they're at goal, they go back to the primary care provider or the specialist provider, and then the pharmacist is monitoring that dashboard and seeing who's falling out on a regular basis. So it's population management, but because we have an outstanding EMR that's built around patient care, it makes it easy. And it's a whole different game, I think, with others of you are dealing with.
Yeah, so jealous, Anthony. I left right when that new EHR came in from the VA. So you're right. It's very difficult, as Jessica mentioned. However, we have identified some amazing commercial partners that have created EHR type interfaces that can connect with med groups, with health plans, pharmacy, and put it all in one place. And it is possible for providers to be able to access that information. But at the end of the day, after every visit with a pharmacist in our program, the pharmacist sends a communication, a summary of care that happened to the primary care provider that the primary care provider can review, enter into the medical record that they have. So there's never any lapse in communication, in awareness of what the pharmacists are doing with these patients.
I will say, as the VA transitions over to Cerner, the Cerner platform didn't have much for ambulatory care, whereas the VA was, the biggest ambulatory care that you could be. And so their system's getting a lot better because of the billions of dollars that are being spent by the government to convert over to, remember, it's not just VA, it's VA, Department of Defense, Indian Health. We're all going to be on the same Cerner platform eventually. So there has been some significant advancements, and that is creating some interoperability that we have not had before. I still think the missing link is that interoperability with retail pharmacy that is going to be a challenge in the years to come.
Yep. Great.
For our two pharmacists, I have a somewhat provocative question, and that is, do you see in the future some of your duties and responsibilities being taken over by AI? In other words, are there things that are routinely enough that you could see that a very sophisticated AI program could unload you so that you'd have more time for these personal interactions?
Yes, I believe so. I think there's opportunities to look at various disease states, labs, medications that they're taking to find out which members need a pharmacist intervention. So something like a complexity score, or so that's things that we're looking at. We're also looking at developing a social risk score, which members we felt may need a social, and pair that up with adherence. So sometimes I think with medication adherence, it's not just that the patient is not able to take it, they don't understand it, it's because they can't afford it, or they're worried about housing and other issues. So how can we help triage that member to the community resources to help them with their medication? So that's something else that we're also trying to look into. We're trying to understand the needs that our members need help with.
Lynn, you're exactly right. I'm going to punt this to Jessica. Jessica, why don't you talk a little bit about our data platform partner and their AI capabilities?
Yeah, so exactly the things you all have been mentioning. So the current platform that we're using, first of all, tries to make the pharmacist visit more efficient in the sense that when they're in there and when the meds have been populated, the labs have been populated, really everything about the patient with respect to adherence. And then there are questions about what they call them as smart questions. And depending on the responses that the pharmacist enters for all of these smart questions, which some are based on the disease, some are based on lab results, some are based on, can I drive to the pharmacy to pick up my meds every month? And then the system actually generates what they call DRPs, drug-related problems. But those are not specifically just your traditional drug-drug interactions and dosage issues and things like that. It's inclusive of all that, but it also highlights any social determinants of health issues, transportation, diet issues, really anything, vaccinations, anything that kind of gets populated using this AI technology based on the responses to these questions. So it helps the pharmacists become more efficient in the visit as well. And then they can address a few of those drug-related problems in one visit and come back to the next visit, et cetera.
And I would say in the VA, we're already using a lot of these clinical dashboards that aggregate all of this data to try and do the same thing. What we're trying to do is make sure that not only our pharmacists are working at the top of their license, but their technicians are working at the top of their license, and really drilling down as to who needs to do what, because in order for our clinical pharmacy practitioners to be the most effective, they have to offload things as well. And there's a lot of things that either automation, computers, or technicians or technical support can do that the pharmacists are doing right now, and it's wasting their time that they could be doing direct patient care activities. So I think it's important to think not only AI in terms of computer algorithms that are going to predict, who are your at-risk patients, but the use of automation and the use of other clinicians and other health techs and pharmacy techs and other people is going to build the most efficient system that we could build.
Well, with that, Hattie had to step off the call. So does anyone want to look through the Q&A anymore and see if there were any questions that we missed, or if there's any more questions from our panel?
I don't see any Q&As that are open.
No chats either.
Good. Well, I'd like to thank everybody for excellent presentations. And I will tell you that every day that I get to work with my clinical pharmacist, I am thankful. And when we round on our inpatient service, I'm also thankful that we have clinical pharmacists. So thanks everyone for a great presentation, and have a great night.
Thank you all.
And I
Thank you.
look forward to next March 15th. Instead of beware the Ides of March, I'm looking forward to our new pharmacist for comfort on our next March 15th. So thanks for our speakers today and for all the participants, and have a great evening.
You too, everyone.
Thank you.
Thank you. Nice to
Bye.
meet everyone.